Okay, so another MLA conditions. So we're looking at meningitis and encephalitis, which I put together for obvious reasons, because the two areas that are involved are next door neighbours. So the meninges, think of those as the lining that surround the brain. There's 3 layers of that, and the encephala in encephalitis is the substance of the brain itself, the parenchyma, or the substance of the brain. Remember that itis just means inflammation. We think of encephalitis and meningitis being infective because that's the commonest thing and that's the thing that will kill people acutely. But it's inflammation from any cause. So you can get sterile meningitis or encephalitis, and you also get autoimmune. So we'll start with meningitis. So this is quite a graphic picture of somebody with, at post-mortem obviously, who has sort of pus underlying the meninges, and that was the cause of their demise. And it's inflammation of the meninges from any cause. Now, we think of bacterial meningitis, so meningococcal, strep, Haemophilus. Listeria is one to think about, particularly if you work with adults in hospital, and that's more likely in people who are immunosuppressed and people who are elderly, sort of over the age of 65. So if you're treating somebody for meningitis in hospital and they meet those criteria, you also need to include medications that will cover listeria, because they're not often. Viral meningitis is much more common, rate limiting. Generally, we give people antivirals if that's suspected, but it tends to resolve itself. People can feel very poorly, but generally they wouldn't be damaged by that. The important thing is not to miss bacterial meningitis, which is very life-threatening. And then there are aseptic meningitides, which is the plural, because why not? I have to make it complicated. An aseptic meningitis, generally we think of as things like medications or sometimes malignancy. So a malignant meningitis we would call leptomeningeal meningitis or spread. People are very, very poorly and their cranial nerves are involved, and that's often quite apparent quite quickly. And we would look for malignant cells in CSF. With drugs, what you might see is sort of pattern of is people coming in with neck stiffness and headache. They'll come in repeatedly. They'll have scans, LPs, which are normal, and you might sort of find that they have a bad headache to start with. They take anti-inflammatories, and then all of this develops, because you can get a group of people that develop aseptic meningitis from non-steroidals, which are very commonly used. So symptoms of meningitis, I think you'll all know this. So fever. Sometimes people won't manifest such an obvious fever, particularly if they're immunosuppressed and elderly, so bear that in mind. Classically, headache, sometimes a thunderclap headache, like that. We usually think of subarachnoid hemorrhage causing that, but also meningitis can. Neck stiffness, so remember your Koenig's sign, so if your meninges are inflamed, if you bend the knee or you bend the neck, that disrupts the sort of smooth lie of the meninges, and that irritates and causes pain. People can be very obtunded, so they can be confused and disorientated. Systemically unwell, they might have a rash. Remember your non-blanching rash, you've always been told about that. They may have seizures, and they may have systemic sepsis as well. So there are very clear protocols about how to manage bacterial meningitis pre-hospital and in hospital. So you give antibiotics immediately and empirically. So you do not delay, you give. You don't delay for a lumbar puncture, because time is life. So you give immediately, and that can be life-saving. Admitted to hospital if they're given antibiotics outside of a hospital setting. Blood tests, blood cultures, because that may pick up your causative organism, particularly if somebody's not safe to have a lumbar puncture, and blood glucose. A lumbar puncture, so classically, imaging not necessary before procedure against concerns about raised intracranial pressure. In the context of somebody being very unwell, you might struggle to do fundoscopy. I think it would be a very brave practitioner that would not do at least a CT scan in somebody very unwell before a lumbar puncture. That's sort of the modern take on that. You would look for neurological features, weakness, numbness, seizure counts, reduced cognitive or awareness, pupillary reflexes. If somebody has a dilated pupil, that suggests raised intracranial pressure. Generally, it's very difficult to detect subtle neurological signs if somebody is not well and obtunded, so bear that in mind. If somebody is not safe to have a lumbar puncture, you treat empirically, and hopefully your blood cultures will confirm that what you're treating is correct in terms of antibiotics. Steroids, there is now good evidence for steroids. If there's bacterial meningitis, which is strongly suspected, you give steroids after your first shot of antibiotics, and that reduces the risk of particularly deafness in younger people, and infectious diseases can support with that. It's a notifiable disease, bacterial meningitis, so public health agencies need to be informed so that other people can be contacted in case they're at risk. Sometimes close contacts are given treatment, and meningitis, all people that have bacterial meningitis should be tested for HIV, and also technically viral meningitis as well. So encephalitis, so rather than the lining of the brain, this is the substance of the brain. So this group of patients, classically, I think the way to think about it is they may look less overtly unwell, but they are just not right. And people will often, it's a slightly unsatisfactory presentation. They're just not right. Well, what do you mean by that? They're just not right. Their behaviour might be subtly different. They might sort of struggle with their normal tasks. Their personality might be a bit altered, and it can be quite subtle. The most common cause is herpes simplex, type 1 more than type 2. And this can be devastating if not promptly treated. Even if promptly treated, the damage to the temporal lobes can be extensive, and memory problems can be significant and can prevent normal function. Other viruses are more likely if somebody's immunocompromised, if they're HIV positive or treated with immunosuppressants. And I see autoimmune forms as well. When somebody has encephalitis, viruses are ruled out. And the one that we tend to think of is NMDA receptor encephalitis, which can cause lots of neuropsychiatric behaviours and a movement disorder as well. Lots of autonomic features, so we can get tachyarrhythmias, drops in blood pressure, can be very scary, and it tends to happen in young women, particularly in the context of an ovarian teratoma. So we look for fever, which may not be there in autoimmune forms, personality and behavioural change, which I've mentioned. Generally, it can be this prodrome can be over a couple of weeks. Seizures are new neurological features, so if somebody has weakness or papilledema, so swelling behind the eyes, but particularly seizures, we think of encephalitis, and it can be slower than you think over weeks. So in terms of investigations, we obviously want an MRI to look at the parenchyma, the substance of the brain, but in the acute setting, you probably want to get a CT scan to make sure there's no bleed or stroke or any or tumour, because obviously the patient probably doesn't have a lot of information to give you. They are unwell, and you want to do a lumbar puncture. So I would generally do a CT. CSF, you would not wait for treatment again. You would give treatment before taking the CSF, particularly if there's going to be a delay with the cyclovir if you suspect viral encephalitis, and you should have a low threshold for that. And you send that for PCR as well as cells and biochemistry. And then after that, when the patient is established on treatment and you are taking care of them and they're more stable, you can then get an MRI. And you're looking for a signal change, particularly in the temporal lobes, which can be unilateral one side or it can be bilateral. And I have some imaging here showing some left-sided temporal and hippocampal signal change. And this patient, I think, had HSV2. And you can also do an EEG if it's difficult to tell whether somebody is having ongoing seizures which are non-convulsive. It can be hard to distinguish between that and overall behavioural and personality change in encephalitis, so an EEG can be helpful there. Treatment, give intravenous acyclovir. If you're thinking to yourself, should I think about giving this person a cyclovir because they may have encephalitis, you should have already done it. Because the longer you delay, the more the brain is damaged irreversibly by the virus, just eating through the temporal lobes. So if you think, maybe I should, do it. And then if you can't, so if there's a sufficient amount of time between applying the treatment and the lumbar puncture, or if it's just not clear, you probably have committed to give for 14 to 21 days, keeping an eye on renal function. So autoimmune encephalitis. So particularly in older people, we think about malignancy as a cause, a paraneoplastic encephalitis. You get the antibodies back weeks and weeks after the presentation, so you can't wait for treatment. And different antibodies can present differently. So I have some videos here. I don't know if they're going to work. Possibly not. Ah, well. Shame. But NMDA encephalitis, what this shows is a young woman who is groaning, arching her back, and she has a movement disorder of the face. And this is an older lady who has intermittent sort of faciobrachiodystotic seizures. So face, arm, funny posture, sort of repeated movements like that. And that's typical of LGI1 encephalitis, which is associated with cancers in the middle-aged and the older person. So things to think about: meningoencephalitis. Elderly people may have less specific symptoms, so you need to bear that in mind. They may not overtly sort of announce, I have meningitis or I have encephalitis, in the way that younger people might, particularly if they're immunosuppressed, so bear that in mind. If you're over 65 and immunosuppressed and you suspect meningitis, cover for listeria. Depends on your own guidance, usually amoxicillin. Atypicals, if somebody's immunosuppressed, things like tuberculosis or cryptococcus are important to think about and are more likely. You can get crossover symptoms, so meningoencephalitis, with both being present. And quite often people are started empirically on antibacterials and antivirals. And then when you get the test back, you can trim those off as appropriate. And it is important to consider HIV testing in meningitis and encephalitis, because you can get that when you're seroconverting with HIV. And people can recurrently come in with either aseptic or viral meningitis or encephalitis before the penny drops that this young person probably has HIV.